how to assess carotid stenosis with ultrasound. That's what Muriel Springer will show us. She will first show how to prepare the patient, then the morphological characteristics of the carotid arteries and plaques, and then she will move to how to assess the carotid stenosis severity using the most appropriate method.
Today I'm going to show you how to perform a carotid examination with echo Doppler, and especially to show you how to assess the severity of the carotid stenosis. A very important thing, of course, before beginning is your position. You can stand at the head of your patient, but if you're a cardiologist, you will probably prefer to sit at his side, on the left side or the right side, as you prefer. So we're going to begin. I think it's easier to ask your patient to turn his head on the opposite side or this way. And it's easier to begin always with the same side. So it's easier to begin with the right side and then the left side, or if you prefer the opposite. But don't change, otherwise you might be mistaken. So I'm going to begin with the right side of the patient, and I ask him to turn his head like that. This patient was admitted for a stroke in the territory of the left internal carotid artery. First, I check the right common carotid artery, and you can see here you have the common carotid artery, and I have a good definition of the intima media, the arterial wall. I think it's better to begin with this posterior view of the carotid artery, and you put your probe just at the posterior edge of the sternocleidomastoidean muscle. Here's the image. Then you can turn on the color Doppler. As you may see, for cardiac examination, it's the same. You have a scale here with red and blue flow. Here is the carotid artery, and here is the vein, the jugular vein. And you can switch on pulse Doppler. You have here. And you have a peak systolic velocity and a diastolic velocity here. You can also do the same examination with an anterior view. And you just put your probe on the anterior edge of the muscle with color Doppler and E-flow. Then you move to the bifurcation, the carotid bifurcation. You can see here the common carotid artery, and here the bulb of the internal carotid artery. And you can see here a structure which is a plaque. This plaque is hypoechogenic, you can see here, and a bit calcified. You can measure it, 1.5 millimeters. And then you turn on the color Doppler, and you can see here the flow in the common carotid artery, the internal carotid artery, and here the external carotid artery. You can see here the plaque we've seen just before. when you want to measure the plaque, you must switch on the color Doppler or E-flow Doppler. Otherwise, if your plaque is hypoechogenic, you might miss some part of it and underestimate it. To evaluate the severity of the carotid stenosis, you must use peak systolic velocity. Here there's no carotid stenosis, but I'm going to show you how to assess the velocity. Here you must put steer U beam. It should be in the direction of the blood flow. And here you can measure peak systolic velocity. It's about 55 centimeters per second, and the diastolic velocity. This one is a wrong way to do it. You can see that my beam is not in the direction of blood flow, and you can see that velocities are underestimated. This one is even worse. You can see that the blood flow goes this way, and my steer is here. It's wrong. This one is a good way to do it. I have the incident beam here in the direction of the blood flow, and I have this beam here parallel to blood flow. But the incident angle, also called theta angle, is 64 degrees. It should be less than 60 degrees, between 30 and 60 degrees. So that's it. If you have an angle, theta angle or incident angle above 60 degrees, you will overestimate your velocities. And I'm going to show you later on, to assess the severity of the carotid stenosis, you will use peak systolic velocity. So it's very important not to make mistakes at this stage. You can see here, with the 60 degrees angle, the velocity is about 100 centimeters per second. And with the 75 degrees, it's 200 centimeters per second. Then we'll have a look at the external carotid artery. You can see here we have a different pattern with the lower diastolic velocity. And also the way to distinguish internal carotid artery from external carotid artery is the morphology. For internal carotid artery, you have the bulb. It's larger, wider. And for external carotid artery, it's more tubular. And also you can find branches from external carotid, not from the internal carotid artery, because the first branch is the ophthalmic artery, and you won't see it, of course. Here's the flow in the internal carotid artery. You can see that the end diastolic velocity is higher than in the external carotid artery. With the E-flow, that's the internal carotid artery. And then you will move to vertebral arteries. Here's the vertebral artery. I'm going to show you how to proceed. You come from the carotid, the internal carotid artery, and then you move laterally, externally. You don't change the direction of the probe, and you will see the vertebral artery here with the transverse apophysis. Here is the internal carotid artery. So now back to the common carotid artery and the carotid bifurcation. And here you can see there's a plaque. And just laterally, we see the vertebral artery here with the color flow. That's the flow in the vertebral artery. It looks like the flow in the internal carotid artery, but the velocities are lower. Now we're going to have a transversal view of the carotid. On the neck here, you can see that there's the thyroid here, and here the common carotid artery, and externally you can see the jugular vein. With the flow, E-flow, you can see here the carotid and the jugular vein. Once again. Then I move to the bifurcation. And here you have the external carotid artery. He's swallowing. And the internal carotid artery. That's the bifurcation with the plaque. You've just seen the plaque from the common carotid artery to the bifurcation. And this is, now we're moving to the subclavian artery with the flow. The flow is different because the subclavian artery gives blood to the arm at its high resistive territory. So you can see that the shape of the curve is quite different. It's there's three components: systolic, early diastolic, and mid-diastolic flow. Now we're going to move to the left carotid. And here you can recognize, I hope, the common carotid artery. It looks the same as the other side, the common carotid artery. Then we move to the bifurcation, and here you can see just the ostium of the internal carotid artery with the plaque. And this plaque is partly calcified, you can see, but there's something more hypoechogenic. Here is the plaque. The stenosis doesn't look quite severe. But when you put the color Doppler on, you can see here that the stenosis is much more severe than we thought it was. And you can see here the flow with aliasing. And aliasing, as for cardiac echo, is a sign of high velocity and stenosis. You can see the stenosis is partly anechogenic here. And anechogenic stenosis are much more dangerous than hyperechogenic ones because they correspond to high lipid stenosis, and they are much more dangerous than calcified one or fibrotic ones. The same with E-flow, and it looks even more severe in E-flow than in color flow. So this is the bulb of the internal carotid artery, and this is the common carotid artery. Now we're going to try to measure the stenosis. The image is quite good, so we're going to measure it with the planimetry. And I measure it here. It's 0.9 millimeters. There are two ways of measuring carotid stenosis. The first one is NASET. from the NASCET study, North American symptomatic carotid trial, and it measures the diameter here inside the stenosis, and it compares it to the diameter when the carotid artery is almost normal. This is about 76% stenosis. There's another way to measure the stenosis. It's according to ECST, European Carotid Symptomatic Trials, and then it compares the stenosis, the diameter here inside the stenosis, and the normal diameter here at the same site, and you can see that's 86, almost 87%. So usually we must use the NASCET vocabulary because it corresponds to CT scan and MRI, and usually we don't use ECST. If you want to use ECST measurement, you must specify it and be cautious, because people who will read your paper maybe won't understand what you've said. So I think it's much safer to use NASCET. Once again, the stenosis. So, of course, we can measure the stenosis, but sometimes the definition is not good. It's too calcified, so you don't see well. Sometimes the stenosis is eccentric too. So there are pitfalls, and the best way to evaluate the stenosis is to use Doppler. To use Doppler, as for cardiac examination, you will use peak systolic velocity and also end diastolic velocity. Here, you must be careful, as I've just told you before, to steer your box the most parallel to the blood flow, and here to have an angle of less than 60 degrees. Here it's 64, it's almost good. And this is the peak systolic velocity. It's very high. It's 500 centimeters per second. Usually when it's above 120 centimeters per second, it's about 50% stenosis. When it's more than 210 or 230 centimeters per second, it's about 70% stenosis. And what's important too is end diastolic velocity. When it's above 90 or 100 centimeters per second, it's usually more than 70% stenosis. Those are the direct signs of carotid stenosis. But some patients have severe aortic stenosis, or they have a low cardiac output. There's a thrombosis of the opposite carotid artery. So your velocity might be under or overestimated. So to avoid those pitfalls, you will calculate carotid ratio. Carotid ratio, you use peak systolic velocity in the internal carotid artery, and you divide it by the peak systolic ratio in the common carotid artery. And then you more independent of hemodynamic conditions. And usually when it's above 3.7 or 4, it's more than 70% carotid stenosis. Once again, this stenosis. And those were the direct signs of carotid stenosis. Now there are indirect signs, And of course, you will check blood flow downstream in the internal carotid artery. Here's the distal cervical internal carotid artery, and you can see that the flow is damped. The velocity is much lower, and the ascension time is longer. This is the flow in the external carotid artery. It's a normal flow. So for the assessment of internal carotid artery stenosis, you use 2D echo if you can, if it's not too calcified. You use direct signs and indirect signs, and all of them must match, of course. Otherwise, there's a problem, and you must find what problem. Once again, this stenosis here. Now I'm moving from the external carotid artery to the internal carotid artery, just moving my hand like that. Internal, external, internal, external. And then back to the vertebral artery with the flow that looks like the internal carotid artery, but a lower systolic velocity. And then to the bifurcation. Here is the internal carotid artery in color Doppler. This is the external one, and you can see here the aliasing. So there's a severe stenosis, but as you can see with E-flow, the stenosis looks less severe, because E-flow gives a better definition of the edge of the internal channel. And you can use the E-flow to measure the stenosis by the area method. Here's the stenosis, and then you compare it as I've just done with the Nesset method, but instead of using diameter measurements, I use area measurements. And as you can see, I have an 84% stenosis. It's a well-known problem that when you use area measurement, you will overestimate the stenosis. So if you have an eccentric stenosis, you're allowed to use area measurement, but just keep in mind that you will overestimate the stenosis, and be careful when you communicate with other doctors about your patient. It's not an 84 stenosis. It's 84% according to area measurement, but it's about 75% according to Nesset. Now we're going to check for other indirect signs, and of course we'll have a look at the ophthalmic arteries. So I will ask my patient to shut his eyes. And this is the eye here, the eye ball. And here you have the optic nerve, and on the side, the ophthalmic artery. The blood flow goes to the eyeball, and it's blue, it's normal. Here is the flow, with the peak systolic flow is about 50 centimeters per second. It's a bit high, but probably because there's a severe stenosis on the other side. Now I move to the other eye, and you can see here that the peak systolic velocity is about 20, so much lower than the other one. When there's a severe stenosis in the internal carotid artery, you have a lower velocity, or sometimes the blood flow is in the other direction. Now, if you want, I can show you another indirect sound, but coming from transcranial Doppler. To perform transcranial Doppler, you must use this probe. It's your cardiac probe, but with the special settings. And then I'm going to ask my patient to turn his head on this side. And I'll put the probe here. And you must just try to find a window. This is the temporal window. And you must try to find this little butterfly, which is the cerebral peduncles here. And then you have the circle of Willis here, with the middle cerebral artery here, the posterior cerebral artery here, the first segment of the anterior cerebral artery here. The anterior communicant artery is not shown here because it's very small. Here you have the second segment of the anterior cerebral artery, and this is the other side here with the left anterior cerebral artery. Here is a Doppler on the middle cerebral artery. You can see here with high velocity, it's about 120 centimeters per second. It's normal high. This is the same one. This is the posterior cerebral artery. This is the carotid siphon. You just move a bit the direction of your probe to find it. You don't move your probe, just the inclination. And here you have the cerebral arteries, the middle cerebral arteries here, the anterior arteries here, with high velocity and this blood flow is in abnormal direction because it gives blood to the other part. And here on the other side, you have a damped signal here. It's the middle cerebral artery, and you can see that the peak velocity is about 30 centimeters per second. This is much, much lower than on the other side, with an acceleration time which is much longer than on the other side. So these are indirect signs of very severe carotid stenosis, more than 80%. So I just want to emphasize that for carotid examination, you must be very strict, and you before concluding there's severe stenosis, you must check direct and indirect signs, and you won't make a diagnosis with one argument only.
Key points of this examination are that we have to provide a systematic approach, to have a good alignment with the flow, and also not to rely on one single parameters to assess carotid stenosis. And finally, to look at direct signs, but also to indirect signs at the level of the other arteries.